Thank you very much. And in next 60 minutes, we will try and understand the localization. So rather than calling localization, we like to call it anatomy or microanatomy of different systems. And as Dr. Naglata said, usually we use the level of lesion, anatomical localization, etc., mainly for the CNS diseases. But this is not just anatomical localization. This is an analysis of a given situation, a medical condition, to arrive at a diagnosis where you are not looking at a spot diagnosis. And many times when you think of make a diagnosis on a spot basis, you may or may not always be accurate. So it's good to have a proper analytical mind in order to assess what we are thinking. So as Dr. Naglata said, this lecture has been, I would say, adopted from or modified from what a program called STEER. And there is a book also available on STEER, but it's advisable if you can attend STEER, or I will try and share a link if it is available of a full 6 or 7 hour session on STEER. But till then, we will try and finish it in an hour, at least the main points. So what does STEER stand for? It's about sensitizing to think and thereby enabling excellence and performing rationally. It's been abbreviated as STEER, and by none other than my teacher, Dr. Amdekar sir, along with Khare sir, my friend, Dr. Rajesh Chokhani, and my dear friend, late Dr. Anand Chandelia. So one of the full program of STEER from which I have taken today's session. I'm taking today's session. So these are some of the books which are available. Okay, I have no commercial interest, and I'm sure neither of the 4 people whom I have shown earlier have any interest. But this is just that this content is not available online, and it's good to read these books not only for exams but even for your practice time as well. Okay, and this is the book that I was talking about, the STEER program, where the focus is on learning how to analyze a case clinically, do a rational investigation and management. So let's look at what is our priority at the first contact with the patient. Can anybody write on the chat box, what is your first priority when you see a patient?
All of you can unmute and answer as well.
Yeah, feel free, please. Or you can write on the chat box. I'm not able to see the chat. Yeah, okay. Listen to the complaints. Excellent. Very good. Anything else? First, make rapport. Okay, Dr. Priyanka. Prioritize the chief complaints. Very good. Dr. Mona says whether the patient is sick, and that is an excellent answer. Triage is an excellent answer as well. So we'll show you the first and foremost thing. Now, this is going to sound silly, but it's very important to say, I like to ask myself a question whenever I see the patient. Does this patient require emergency A&E management stroke resuscitation? If not, does this patient require ICU admission? Does this patient require ward admission? Does this patient require investigation? Or I have time and liberty to sit and manage this patient at my own time? Okay, so the first thing is to rule out critical situation. The second part is that we take relevant focused history, we perform focused examination, and we decide whether we need to do any investigations or not. Finally, we decide to treat the patient. Now, when we say treat, we can either give symptomatic treatment, or if we have a confirmed diagnosis, then we treat the problem completely. And finally, as we said, we must counsel the patient. All these together is what we would put it under a patient care. And what is the aim of history and examination? So when we do the examination, and when we do history and examination, and when we are presenting a case in the exam, we like to say few things in the diagnosis, right? So what do we say? We say what is the anatomy? That means we are trying to say where is the site of the lesion. So question is where. The next question is what. So what is wrong with the patient? So physiology has been disturbed, thereby leading to pathology. That means what type of problem it is. Next, we ask ourselves, why has this happened or why is this problem in the first place? So that is what we look at, the etiology or cause of the disease. And finally, we want to see how much is the disease. When we say how much, it means what is the extent of the disease, what disability, malfunction, restriction the disease is causing to the patient. But today, because we have about an hour or so, we are going to focus on the anatomy part. That means we are going to look at the site of the lesion or identify where the problem is in a given case. So when we look at anatomy, we first look at which system is involved. Now this is going to sound again very childish, that, oh, this is CT or MRI. But believe me, a lot of us make mistakes when just an image is shown, whether it's a CT or an MRI. And the same way, when you look at a condition of a child who is having tachypnea and you want to label that as a respiratory symptom, for all you know, you may land up with an endocrine problem like a DKA or land up with a CNS problem with a raised ICT. So it's important to identify the system. Next, you want to identify which organ is affected, and subsequently, we will look at microanatomy of that particular system. So today, we'll try and cover a few systems and not look at CNS and CVS. That's like a disclaimer to start with. Now, when you are going for history, you have few options. You have a chief complaint or a symptom. Now, what is the single symptom that is sorry. If you have a single symptom, how do you proceed? If you have a single symptom, you go with the standard way of saying ODP or onset, duration, and progress. And after that, you look at the associated symptoms and then you complete the remaining part of the history. Some of the common conditions like fever, pain, limp, and many other conditions, you can have further details than just ODP. And this is a new mnemonic that I have learned. What does this stand for? It stands for onset, location, duration, character, aggravating and relieving factors, timing of the problem, meaning whether it is more in the morning, evening, after exercise, etc., etc. And finally, the severity of the disease, severity of the symptom, sorry. So once you have these details, you will have fair idea and your problem will get narrowed down much easier. But if you have multiple chief complaints, how do you approach it? You approach it by identifying the main condition. Then you say which is the most important complaint from patient's point of view also and from your point of view also. A patient will come and say, "Pura din khaste hi rehta hai." But if the child is also breathless and is showing now complaining of poor mental alertness, for you the chief complaint most important complaint may be an altered mental status rather than looking at the cough. So you decide what is the main symptom. It's also important to know what is the timing of the complaint and what is the sequence of the complaint. So this is very important, and what I'm trying to show you are some of the concepts that you can use across the board. So I'll give you an example. Suppose we are looking at main complaint. We follow this principle of primus inter pares, that is first amongst equal. That means you have a complaint where a patient feels all three are important, but you need to decide which is the first or the most important complaint. And sometimes when all of them are equal, the complaint that started first gives you a better idea. So let's take an example of a 5-year-old girl who comes with fever, vomiting, and abdominal pain. Okay. Now, suppose fever was the most important complaint. Can you tell me what likely situations that you would be encountering? You can answer on your chat box. So what we are saying is, you can even unmute yourself and speak. Ayushi, you want to unmute and speak?
Hepatitis.
UTI, sir.
Hepatitis, excellent. What else?
UTI.
UTI, okay, very good.
Acute gastroenteritis.
Okay. Anything else? Yeah, the chat have written appendicitis, excellent. Gastroenteritis. So now I will enterocolitis, excellent. So we have all these options. Now, how do we say which is more important? Now, when I say fever came first, means I am trying to say that vomiting and abdominal pain came subsequently. Then I would think of pyelonephritis before I think of hepatitis. Because if it is hepatitis, which symptom would come first out of these three?
Vomiting. Abdominal pain.
So vomiting would come much earlier if we are dealing with hepatitis compared to a pyelonephritis. See, you must remember that when you have detailed history, you may always know what you are dealing with. But these principles are useful when you are stuck or when you don't have an answer, or sometimes even when you have an answer, but it doesn't fit into this, you ask yourself twice whether what I'm thinking is correct or not. And suppose abdominal pain is most first thing, and then child started vomiting and developed fever, then what would you think?
Obstruction.
Appendicitis, excellent. Max writes, Max has written appendicitis here. Priyanka also said appendicitis. Correct. So gastroenteritis also can come, but that comes first with vomiting, then abdominal pain, or abdominal pain and vomiting coming at the same time. And if it is gastroenteritis, then abdominal pain and vomiting would be followed by loose motions, correct? But here we don't have history of loose motions. So here we think about some abdominal condition or surgical condition where it's an acute abdomen situation. Now again, I'm sure that these are not the only three conditions. But what we are trying to emphasize is, as we earlier, when we asked what can be there for a fever, vomiting, and abdominal pain, we had so many differentials. But now if you see further, and depending upon what has come first, there is likelihood of that this particular condition being more common. We said if there is a sequence of event. So suppose a child has fever, cough, and breathlessness. Let's say take a common example of fever, cough, and breathlessness, and try to see how we can have it differently. So if the child who comes with fever develops cough, and after some time, an infant who develops breathlessness, what is your likely diagnosis?
It could be LRTI. Pneumonia.
LRTI, pneumonia. Okay. What else?
Bronchiolitis.
Bronchiolitis, sir.
Bronchiolitis. Okay. Very good. I'm writing over here so I can discuss further with you. What else? Common things first. Croup. Okay. Croup means croup should have a stridor or noisy breathing. But yeah, okay.
Scarlet fever.
Pneumonia getting into empyema. Okay. Fine. Any other thing? The child has foreign body. Very good. Okay. Asthma. Excellent. So in one infant, as Dr. Manju has written, Valerie, or viral associated disease. Correct. Excellent. So let's have a look at what we have written here. So we have fever, cough, breathlessness, Valerie. Now remember, we are going to juggle around with these three symptoms and try to see if we have any different sequence leading to a different diagnosis. Okay. Now suppose the child had fever first, developed breathlessness, meaning became tachypneic, and the cough was not there. Cough developed after 2 days. Then what is your diagnosis? Would you still consider Valerie?
Pneumonia.
Pneumonia. Why pneumonia with no cough?
If it is bronchopneumonia, it is in the airway, so mostly.
Okay, that's a thought. So you have to remember that
Mostly
pneumonia
seen in
child
North
comes with
India.
fever and tachypnea. Cough starts usually when there is breakdown of pneumonia, correct? So the child may present only with fever and breathlessness, and cough will become prominent only after certain time. On the other hand, you have an infant who was already, mother says, was already breathless, developed fever and had cough. The child who was already breathless, developed fever and cough. Now see, this is when we are discussing a case, you always think that we are talking about the respiratory conditions only, correct? I'm saying the child was already breathless. This is not a child who is apparently normal before.
Congenital anomalies.
Correct. So either respiratory or cardiac, right? So it could be a VSD who develops a left to right shunt who has developed now lower respiratory infection. So that is why the child was already tachypneic, now developed infection, had fever and cough. Okay. So that's one possibility. But suppose the mother says child started coughing suddenly, became breathless, then was a little bit okay for 2 days and then started getting fever. Then what is your thought?
Foreign body. Foreign body.
Foreign body. Brilliant. Excellent. I'm so happy with you guys. So there what we are trying to say is that cough and breathlessness came up first and fever happened later. Later, because it may be an organic foreign body which then develop fever or whatever. The idea to emphasize here is that cough and breathless starting suddenly, you don't think about Walry or pneumonia, you think about something else. That is the point. But suppose after doing all this and you still have no clue, then you look for clue from the other side that we call left side. We used to call it left-sided history, or look for other personal details. And the most important statement, as I said earlier, is apparently normal. So in your history, you try to decide whether this child was normal before the current presentation. And how do we decide that? One most important factor is to decide by growth. And when we say growth, we say not only today's growth, but if possible, growth charts. So if the child has few readings in the past, you will come to know whether the child has had had some problem before, or only this problem is an acute problem. So can somebody tell me how on basis of growth you will decide whether this is an acute problem or acute or chronic problem?
So
Weight
weight
affected.
mainly
Acute.
points to chronic.
Height affected, then chronic.
Excellent. So if only weight is affected, then you're looking at a possibly an acute or a subacute problem. And if the problem is chronic, what will be affected?
Height.
Height and weight.
Length and weight.
Very good. So again, height and weight both will be affected, but weight may be affected more, but height will also be affected. That would be a chronic problem. Next, you want to ask for family history. So what do you want? Tell me one condition, the most common condition in which you ask for family history. The most common condition.
History of TB.
TB contact.
History of TB contact.
Asthma.
The most common disease in the world.
TB, tuberculosis.
Malnutrition.
We all have removed our mask. Doesn't mean that the disease is gone.
Malnutrition.
COVID, right?
COVID.
COVID, correct. COVID, correct. Now I take your point. Now we used to always ask for viral disease point of view, but I'm saying currently we are talking about this. Still we talk about this COVID. But I take your point that you have to ask for history from tuberculosis, viral disease, any other child going to school. Now, suppose you have a history of an elder kid going to school and you have an infant who is coughing. What is your, how will it help you?
History of URTI.
Correct. Anything else? Any bacterial condition?
Mycoplasma.
Excellent, Dr. Abanda, mycoplasma, right? So what I'm trying to emphasize here is you must take proper history when you don't have enough clues coming on from your standard chief complaints. Then you need to ask for birth history, developmental history, social history, and so on and so forth. And make sure that if you find any lead, just go through in detail. So suppose you have another family member who has suffered from a similar problem. Don't just say one sentence on that. Try to get a proper detailed history of when the problem, suppose there is one more history of seizure in the family. Take full proper details about when it happened, what happened, etc., etc. And why we need to know all this? Because see, all the up-to-dates and Nelson and Clinical Key and all the books will give you all the information. But to convert it have the analysis about liver. So what we do is we divide liver into 4. Like in CNS, we start with what? Upper motor neuron, lower motor neuron, correct? So here, can somebody tell me what are your different parts of microanatomy of liver as far as clinical analysis is concerned? One we said
Pre-sinusoidal, sinusoidal, post-sinusoidal.
Okay, sinusoidal, post-sinusoidal, and pre-sinusoidal.
Lobule.
That all come under portal system. Correct. Very good. Okay, then there is a biliary area which we have discussed, and we said portal.
Liver part.
Reticular endothelial system.
Excellent. And the 4th one is reticular endothelial system. So with these 4 things, we know that we are going to any child who comes where we localize the system to hepatobiliary, we will try to see which of these 4 is predominantly affected, number 1. There could be a combination because we can have a situation where there could be a hepatobiliary state problem or portal affection to start with, and eventually hepatocytes also get involved. But which is the primary problem, we'll try to understand. So to give you an example, between hepatocyte and biliary, so what are the features of hepatocyte involvement?
Jaundice.
Signs of acute liver failure.
Correct. Very good. So signs of acute liver failure. Now, hepatocyte, you have to remember, can be with jaundice or without jaundice also. And we'll come to that. So now we know that we have these 4 issues. So when there is a hepatocyte involvement, you are more likely to have nausea, vomiting if it's an inflammation of the hepatocyte. If there is swelling and inflammation, the liver size will be more. Liver functioning will get affected. So there could be decompensation and jaundice. There could be a bleeding problem, as in coagulopathy. And if there is an acute fulminant problem, there could be encephalopathy also. Overall, the child usually is going to be comparatively sick. Now, if you want to compare between hepatocyte and biliary, the biliary tract gives very high bilirubins compared to hepatocyte injury, direct bilirubin, clay-colored stool, and itching as the predominant feature. Okay, so it's comparatively a non-sick child. I'll give you an example. You have a newborn with cholestasis. You want to differentiate between a neonatal hepatitis versus cholestasis. So that is where we use this differentiation, and we all know how to differentiate between neonatal hepatitis and cholestasis. Okay, am I clear on this? So let's look at this. Now you have jaundice. Jaundice, as you see, so what we are trying to do is we'll take a system, we'll get into the microanatomy, and then we will pick up 1 or 2 important symptoms and try to see the approach thereby using the localization. So if you see a child with jaundice, you have 2 options. Either the jaundice is coming because of liver or because of blood. When we say blood, means we are talking about indirect hyperbilirubinemia. And when looking at liver, we are looking at hepatocyte or biliary tract. So we are not looking at an RE cell affection, and we are not looking at a primary portal system affection. Secondary to a portal problem, you can have anything, which is a separate discussion. So as we said, hepatocyte usually will have hepatomegaly when we are talking, when it is with jaundice. you have hepatocyte dysfunction, starts with nausea, vomiting, anorexia, classically seen in viral hepatitis, and you don't require anything more than symptomatic treatment. But if you have seen some of these viral hepatitis A's, when they are improving, meaning the child starts to look better, appetite is improving, activity is improving, fever is slightly better, but the jaundice shoots up. And if you would have done LFT before and after, previous report was, for example, total bilirubin of 7 with direct, and enzymes were like 3,000 and 3,500. But later on, when the child is looking better, the enzymes are now say 1,000 or 800, but the bilirubin has gone to 17, 18, direct bilirubin. What symptoms you think the child would have at that time?
Itching.
Itching, excellent. What else? So here there's a catch actually. Clay-colored stools. Okay, so big children usually don't have so easily clay-colored stools, but I get your point that you are thinking about a biliary tract involvement, which is very good. And here the differentiation comes that if the child is more sick and you have this problem, then you have to rule out fulminant hepatitis. But more often than not, when the child is looking better and you have these kind of abnormal LFT with jaundice increasing, you think of a biliary tract involvement, and that's where you can counsel the patient that you are not dealing with anything major and the child will improve eventually. Okay, but suppose, now why are we discussing or vomiting? Then think very carefully before saying it is viral A or E. And that's why I think somebody has written on the chat that it's a metabolic disease. Very good. And which metabolic disease you are looking at? Always think about conditions which are treatable. Okay, so Wilson's, very good. So when you think of a differential diagnosis, as a rule, always tell yourself what are critical illnesses, what are treatable illnesses, and what are common illnesses. Once you have these three things taken care, then you can fall back on your systematic thinking. But any condition, first you say, is there anything life-threatening happening here or not? Right? Fine. And then we talk about fever and other symptoms, and jaundice comes in later. So here is what we would think about certain other systemic diseases or infection which can lead to jaundice. But this is, again, you have to remember, it's less common because when you have an extra hepatic disease, you have to have hepatocyte, large number of hepatocytes affected before you can land up with jaundice. Pure biliary tract usually has jaundice without hepatomegaly, usually a non-sick child, itching, and clay-colored stool. But usually pure biliary may be hepatobiliary or biliary plus hepatic involvement. Okay, and lastly, we said hematological, which we won't be spending much time now. But if you have a liver disease without jaundice and you want to dissect where it is fitting, think about two conditions. One is an acute condition, which is an anecteric hepatitis. And second is a chronic condition of chronic compensated disease like cirrhosis or even Wilson's, which has still not got into jaundice, because these children, when they develop jaundice, we call it decompensated liver disease. Okay. And how do you decide whether it's a chronic liver disease in that case? Any thoughts?
So when the liver functions are affected, like hypoalbuminemia,
edema.
Okay. Okay.
Growth
So
of
usually
the
that
child.
would also go like more or less like decompensated. But the first thing to pick up would be again your growth. Okay, growth, sleep, food, anorexia, all those things. And over and above that, as you said, hypoalbuminemia or bleeding disorders, and finally jaundice. Now, portal hypertension, pre-sinusoidal. So I will just show you in the next slide the interplay between ascites, liver, and spleen. how do we differentiate different diseases based on these three conditions? So whether it is pre-sinusoidal, sinusoidal, or post-sinusoidal, and if it's an RE cell involvement, you're looking at mainly a hepatomegaly or hepatosplenomegaly. And if there are engorged neck veins, then you are also thinking about constrictive pericarditis in post-sinusoidal situation. Okay, so let's look at this. I will be showing you, and you have to tell me the likely condition. You can write in the chat box or you can speak loudly. You have a child who has ascites and liver, but no spleen palpable. You can tell me the level of lesion and give me an example of the same.
So cardiac causes.
Okay, cardiac will have ascites. Which cardiac?
So constrictive pericarditis mein.
Post-sinusoidal, correct. So post-sinusoidal, what are the conditions you can think of?
But Chiari.
But correct. Yeah. So when you said cardiac, if it's constrictive pericarditis, then again this thing can happen, and so you need to have this, plus, as we said, engorged neck veins. Correct. Now you have a child who has liver, spleen, and ascites. What are you thinking of?
Sinusoidal cause of portal cirrhosis.
Excellent. So give me one example of sinusoidal.
Cirrhosis.
Cirrhosis. Excellent. Or it could be other things also. But basically you're talking about a sinusoidal involvement. Now you have ascites and you have no liver and no spleen.
Extrahepatic portal vein obstruction.
Extrahepatic will have ascites without spleen.
So GI causes.
Malnutrition.
Abdominal cause.
Abdominal cause. Excellent. Renal
Renal
cause.
cause.
Very good.
Renal
So what is
cause.
the renal commonest renal cause?
Nephrotic.
So what we are trying to say here is, if there is no liver, spleen, and only ascites, it's unlikely to be a portal affection, portal system affection, but a local peritoneal problem, which could be or a systemic problem like nephrotic syndrome, tuberculosis, or malignancy. Or we have written cyst here because it will appear like ascites, but it's, and you do a sonography or when you do examination, it looks like a cyst. You can ignore the cyst part, but rest of that is clearly mentioned. And if you have a child with spleen who has no ascites and no liver, then what is it?
Pre-sinusoidal.
EHP. Okay, very good. But again, we have to remember that for this slide, we are thinking about cases of mild musculomegaly, which could be anything from malaria to dengue to storage disorder to malignancy, etc., etc. Correct? But important to remember here is that if it is a portal affection, then you are thinking in terms of extrahepatic portal hypertension. And you have only liver and spleen, but no ascites. Then what are you thinking?
Tropical disease.
Reticuloendothelial system.
Reticuloendothelial system. Very good. Or it could be an infection like enteric fever. No, let's start with common things.
Malaria.
Correct. Kala Azar, malaria. I would have said enteric first, then said malaria. But then you can have miliary-cox, and you can have Kala Azar, and you can have leukemia, you can have storage disorders, and a whole lot of other things. But when you have these three conditions, liver, spleen, and ascites, you look at other dominant symptoms. You remember the first slide where we said, look at the chief complaints or look at the important findings. And if you don't have enough things, look at associated findings. So suppose there is fever associated with it, you will think of infections, inflammations, or malignancy. If you have pallor and bleeding along with this, you think more about hematological causes. And you have jaundice along with liver, spleen, and you're thinking more in terms of a liver disease. Okay, fair enough. There is one more table like this, but I think I'm going to skip this because that's not much into anatomy today. Okay, let's go to GI microanatomy. So when we look at GI microanatomy, we are looking at either small intestine or large intestine. Okay. And when you're looking at diarrhea, you're looking at whether this is an enteral cause or a parenteral or a non-GI cause. Non-GI cause, especially in infants, it could be even a UTI, which comes with vomiting and can come with loose motions. Or it could be an affection of large intestine or a small intestine. How do you differentiate small intestine from large intestine? Any thoughts?
Volume of the stool.
Very good.
Tenesmus will be there sir, for large intestine diarrhea.
Okay. Okay.
And blood in the stool.
Tenesmus will be there. What else?
Blood in the stool if it is mostly large intestine. Small
Okay.
volume large intestine.
Okay.
Foul smelling stools.
Very good.
Content
Okay,
of
fine.
the stool.
So in small now, I would divide them into acute small intestinal problem and chronic small intestinal problem. So acute small intestine problem is classically what? Viral gastroenteritis, correct? So it will be frequent stooling, large quantity, and possible dehydration. If it is a chronic small intestinal affection, there is likelihood of infrequent stools, but abdominal distension and malabsorption and failure to thrive as other symptomatology. On the other hand, as you all said about large intestine, the quantity of stool is usually less. There can be frequent, multiple small stools, may or may not be with blood and mucus, may or may not be with tenesmus, and can have abdominal distension or pain. Okay, so the main differentiating factor between large and small intestine would be to see of small frequent stools versus large watery stools, and blood or no blood. Now we come to vomiting. How do you approach vomiting? What are your thoughts on vomiting?
Bilious, non-bilious, projectile,
Any sick child comes to you, they will almost have, if you ask the parent 2 times or 3 times, they will say, हाँ एक बार उल्टी हुआ था, हाँ 2 बार उल्टी हुआ था. So it's important to make sure whether this is an important complaint or a significant complaint or not. And this holds true for vomiting, for cough, and also for fever. हाँ थोड़ा गरम लगता था. Now you have a problem happening with so many other chief complaints, and whether you want to label that fever as documented or not, same way, vomiting significant or not. Projects, okay, so on the chat, somebody written projectile non-bilious associated with nausea. Excellent. So I would have thought of any vomiting which goes for more than 48 hours or is associated with any red flags is to be considered significant. The next thing in my algorithm is whether it's an abdominal cause of vomiting or central cause of vomiting. What are the central cause? We'll finish the small one first.
Raised ICT.
features of raised ICT.
Excellent.
Abdominal
Raised
migraine.
ICT. What else?
Abdominal migraine.
Abdominal migraine. Okay. That is still abdominal, but
meningitis.
you put it as central. Sorry, I didn't hear that. Toxemia, somebody has written. Okay.
Meningitis.
What else? Meningitis is again raised ICT. Yes.
Drugs affecting the CTZ region.
Metabolic.
Metabolic conditions, right? You have metabolic conditions which can give rise to vomiting, whether it is uremia or whether it is non-GI problem would be non-GI problem in infant, as we mentioned, could be a UTI or it could be hepatitis, correct? These two can give rise to vomiting. And GI would be your gastroenteritis or gastritis or obstructive lesions in the on your GI system. If you have abdominal distension, you will look at it whether it's a localized lesion or a generalized distension. So localized distension will be usually an upper, if it's in the upper abdomen, It can be an organomegaly, that is either a liver or a spleen or liver and spleen. Typically, we like to call that spleens are usually felt by the doctors and the livers are felt by the parents. But if it's a very large spleen, even parents while giving bath in a very thin and young child, they can appreciate a lump over there. Generalized, if it is increasing over hours, that we said ODP, right? Onset, duration, and progress. So if it is increasing over hours, you say it's likely to be an intestinal obstruction, where it could be a paralytic ileus, or it could be any other infection, toxin related, or even electrolyte imbalance like hypokalemia. But if it was increasing for a few days and then it became static, that means the intra-abdominal pressure became equal to the vascular pressure, and then you will think about ascites. But if it has been going on for weeks or months, then you think about hepatosplenomegaly, that is organomegaly, or it could be a cyst where the child would be otherwise okay. And if it's a malignant tumor of whatever reason, like kidney mass or a neuroblastoma or something, then usually it doesn't give rise to abdominal distension, but would come more like a lump on palpation. Okay. Now let's look at the respiratory system microanatomy. So can anybody tell me what is your thought? How do you divide respiratory system?
Upper respiratory tract and lower respiratory tract parenchyma.
Okay, excellent. So this is simple. So we go for upper respiratory, lower respiratory. Lower respiratory, we divide further into airway, pleura, excellent. What else?
Alveoli. Alveoli.
Interstitium, very good. And parenchyma, correct? So you have airway, you have parenchyma, you have pleura, you have interstitial problems. And within the airways, you can divide into upper and lower, lower further into large and small. Okay. So let's look at the characteristics of each part, and then it will be useful for us to narrow down to a problem. So let's look at this. What do you mean by upper airway problem? Classical prototype upper airway problem is what? Examples.
Hepatitis.
Sorry. It could be either an upper respiratory like a sinusitis, rhinosinusitis, but we don't call them into airway too typically, right? So we can think about croup and similar things, croup, epiglottitis, etc., etc. And then lower, large would come into asthma. Sorry, small would come into bronchiolitis. Parenchyma, classical lesion is consolidation, correct? Pneumonia. And pleura, what is the classical problem that you see? There you see pleural effusion, you see empyema or pneumothorax, correct? And interstitium, you have interstitial lung disease, correct? So let's look at some symptoms and see how we can divide each problem into different anatomical parts. Significant airway problem. That means cough will be a significant, if cough is significant, think about airway. Usually cough is not a significant feature of parenchyma, pleura or interstitial lung. If it's a primary respiratory problem, it can be a primary problem from the respiratory system, or it could be, cough could be secondary to non-respiratory, like all the other ones we have said. Could be cardiac, aspiration, GERD, or external compression from mediastinum. Upper airways usually give rise to dry cough, lower airways give rise to wet cough. Even in lower airway, if your wet cough is more than tachypnea, then you think about large airway, as in asthma. And if the tachypnea is significant and cough is not very significant, you think of bronchiolitis. That means the lower small airways are affected. Okay. If the cough is not predominant, then you think about the other three conditions. And that means you're thinking about a lung, parenchyma, pleura, and interstitium. As we said earlier, initially fever, breathlessness, and cough developed later in the course. There could be grunt, intercostal retraction, and signs which have lobar distribution. This is very important to differentiate between lung lobes of pleura follow a different pattern. So that helps you in deciding the anatomical localization of lung versus pleura. Unilateral chest pain with dry cough with or without breathlessness, no chest retraction, and pleural distribution would point towards a pleural condition. And how will a interstitial lung disease present? Can anybody give me some answer on that? How does an interstitial lung disease present? Gradual.
Tachypnea.
Okay, very good. Breathlessness. Cyanosis would be late. So again, important to remember that cyanosis in respiratory condition comes when you are nearing respiratory failure. Unlike in cardiac, where cyanosis comes up much easier. Okay, weight loss, very good. So weight loss is another important thing because usually they're chronic. So classical is, the difference between dyspnea and tachypnea. So interstitial diseases usually come with tachypnea and effort intolerance, if you can say that way. They have generalized signs and it could be acute, but more likely to be slow progressive. Now let's look at breathlessness. Okay. It's going a bit faster because you know most of these things. And so, and in breathlessness, again, as we said, we have to decide whether there is use of accessory muscle or no accessory muscle. That means we are deciding whether this is dyspnea or tachypnea. If it is tachypnea, you think about metabolic conditions or non-respiratory conditions. If it is dyspnea, it's dyspnea at rest or dyspnea on exertion. If it is dyspnea on exertion, it's more likely to be cardiac. If it is dyspnea at rest, then it's going to be more likely to be respiratory. Of course, a cardiac in advanced stage will have dyspnea at rest also if you are into stage 4 of classification. Again, you go to onset, duration, and progress. If it's a sudden onset, you think about foreign body. If it happens over a few weeks, you think in terms of pneumonia. We're talking about breathlessness here, correct? Now, this is an important part that I wanted to share with you. If there are suprasternal retractions, you think about upper airway problem. If there are intercostal retractions, then you think about parenchymal problem, which could be secondary to either a lobar pneumonia or it could be a cardiac cause. But if you have a subcostal retraction, then you think of asthma or bronchiolitis. Okay, so this is your anatomical localization depending upon what signs you see on your respiratory examination. Now let's do this activity one more time. We have about, I think, 10 more minutes. Dr. Naglata or Ashray?
Yes, sir. Yes, sir. But
Yes, sir.
Sure. So let's suppose there is intercostal retraction, grunting, fever, cough, and crepitations. You will think about pneumonia, right? Now suppose there is subcostal retraction, wheezing, cough is predominant, and there are rhonchi. What are you thinking of?
Bronchial
Asthma.
Okay, very good. That's a resounding asthma, and asthma. Very good. Suppose there is no chest retraction, there is no respiratory sound heard,
Bronchiolitis.
but emphysema is heard. Bronchiolitis, excellent. Exampedia is answering well. I don't know what is your name, but you're answering very well. What are we trying to say is that there can be minor retractions can be there, but because very small bronchioles are involved, it's not like a subcostal retraction. It's more like a tachypnea or a dyspnea with cough, but more of emphysema signs. If there are suprasternal retractions with stridor, what are you thinking about? Croup, correct? That we said upper respiratory. Yeah, and if you see here, no, fever is 1+ only. So that's why it's more likely to be croup. If the fever was very severe and the child was very sick, what would you be saying instead of croup?
Epiglottitis.
Epiglottitis. Correct. Excellent. So if you have respiratory distress, but no retraction, no sound, no fever, no cough, and no chest signs.
Decay.
Sorry?
Decay, sir.
Decay. Excellent. Yeah, decay. Correct. That means you're talking about not tachypnea and not dyspnea. But you have very low voice coming out and no other features. Then what are you thinking of?
Laryngeal edema.
Laryngeal edema usually does not have low voice. They have hoarseness of voice. Low voice as in hypophonia. Okay, I'll clarify. Hypophonia.
Pharyngeal abscess.
So again, you have to remember that laryngitis does not give respiratory distress, right? We started with our first requirement is respiratory distress is present. So what does hypophonia or low voice mean? That there is not enough push coming from the respiratory muscles. So you have hypophonia. So there is not enough expiratory force generated to give good voice. Now you have intercostal, subcostal retraction, rhonchi and Krebs, fever also there and cough also present. You're likely to be dealing with
Cardiac.
a pneumonia secondary to or a cardiac condition, correct? Pneumonia is also correct. Recovering pneumonia can have fever plus minus, cough also present, and this could be still having intercostal and subcostal both, so cardiac also present. Okay, so here we are once more to emphasize is once you have all these features, you can think carefully and make a diagnosis which you will be right most of the time. And so you can titrate your investigations and management accordingly. Let's quickly look at in next 5 minutes about renal microanatomy. So when you talk about renal microanatomy, you're looking at upper UTI, lower UTI. Upper UTI is divided, starts from glomerulus. Glomerulus has endothelium, has epithelium. The upper GI, upper renal areas then has interstitium, kidney has interstitium, and it has collecting system, correct? So when there is glomerular affection, usually there will be oliguria, along with hematuria, you have oliguria, hypertension, and mild edema. So the prototype of an endothelial affection is which condition?
Acute glomerulonephritis.
Correct, very good. So acute or just glomerulonephritis, depending upon the duration. But if you have massive edema with minimal or no hematuria, then you think of epithelial affection as in nephrotic condition. So this is how you differentiate nephritic onset of nephrotic or nephrotic onset of nephritic. But if it's an interstitial nephritis, say drug-induced injury, etc., then you have neither edema, no hypertension, but may have only hematuria or the renal failure or renal failure, correct. Collecting system problems as in renal stones, etc., then you have fresh red colored blood, whereas glomeruli usually there is a cola colored blood, and this is a painless hematuria versus collecting system will have a painful hematuria, correct. Upper UTI affection usually has sickness, whether it is UTI with hematuria or one of these conditions with hematuria. But lower UTI, lower urinary tract with hematuria usually has only local symptoms. For edema, it's important to decide which part or organ system is affected. So we need to make sure whether this is protein energy malnutrition, cardiac edema, renal edema, or allergic edema. Okay. So once we are talking about renal, we are looking at localizing it to that it starts from around the eyes. I'm sorry for the fonts. I hope you can see it clearly. Starts from around the eyes, can be seen in renal conditions, in allergic conditions, and sometimes in capillary leak syndromes, you can have early phase with only eye affection. Whereas if you have chronic edema, then and dependent edema, then you think more of cardiac edema. Okay. Sorry. So amongst the edema, if you want to go for anatomical localization, endothelial affection, that means you are talking about glomerulonephritis kind of picture. So that is another easy way to remember. So you say they have mild edema and you have puffiness of face and oliguria, but usually no anasarca. And as we said, if there's anasarca or massive, then you're looking at the anatomical localization in epithelium. Tubules has proteinuria, but no other clinical manifestations. When you're looking at other renal presentations, polyuria, failure to thrive, acidosis, rickets, all this will point towards renal tubular disorder. Acute renal failure will come with edema, cardiac failure, encephalopathy, etc. And chronic renal failure comes with growth failure, anemia, which is not responsive to treatment. You can have rickets, hypertension, and other metabolic abnormalities in the form of phosphorus, potassium, sodium, etc. Of course, you have to remember that in each and every system which spoke about, it's very unlikely that you have one particular area only affected and there will be a combination. You'll have to decide which is the primary and which are the secondary problems. Okay, cardiovascular and CNS we are not touching today. I will take 5 minutes so that we can revise quickly. So we say hepatobiliary, you are looking at hepatocyte, biliary, portal, and RE. Portal we further divide into pre-sinusoidal, sinusoidal, and post-sinusoidal. In diarrhea, in GI, you think about any symptom which is pointing to GI, you say whether the root cause is GI or non-GI, whether it is small intestine or large intestine. In small intestine, whether it is acute or chronic. When you're looking at respiratory, again, you want to make sure whether it is a respiratory problem or a CNS problem or a metabolic problem. If it is a respiratory problem, you want to say whether if cough is the predominant symptoms, you're thinking of airway. If cough is not there as a predominant symptoms, you are looking at parenchyma, pleura, or interstitial lung disease. In airways, we decided that upper airways give rise to striders and lower airways, if they are large airway affection, cough is the predominant symptom. Along with that, there is intercostal retraction, subcostal retraction, and very small airways usually have tachypnea and emphysematous changes like bronchiolitis. In kidney, we said endothelium, prototype being glomerulonephritis. Epithelium has a prototype of nephrotic syndrome. Interstitial lung disease, interstitial renal disease, I'm sorry. And finally, if there is hematuria, if it is cola-colored, painless with crenated RBCs and casts, you are thinking of an upper UTI bleed, upper urinary tract bleed. And if it is painful, red-colored, then you're looking at a lower UTI, lower urinary tract bleed. Finally, let me just end by saying that I would really like all of you to attend the full session whenever you have time and energy. Systematic thinking by relevant history, focused clinical examination leads you to a relevant laboratory test and rational management. And that is what we all have to take home today. And it's not just for exams, but even otherwise. Once you practice this on day-to-day basis, you will build up a confidence and have faith in the system that we have just shown you. so that you will be able to practice this without taking much time. It will become like your second nature. And when you present even in the exam or debate, I would not say argue with the examiner, but when you put forward your case and give reasoning, you will be giving reasoning at a very different level. So thank you, White Army, and